I'm really excited to tell you about a new way of accessing medical care called direct primary care, and my version of it called YourChoice Direct Care. This is something that's growing by leaps and bounds in the United States. About 10 years ago, 150 doctors in the United States did this model. Now it's close to 10,000, and 4 doctors are converting to this in the next 2 months. Is it warbling? In the next 2 months, just in Livingston County alone. So this is an alternative to the classic system, and I'm hopefully going to explain why it's such an important thing. So first I'm going to explain the reasoning, why this kind of a change is needed. Then I'm going to describe what we are. I'm going to explain insurance products that go along with this just quickly. Again, Sue's going to follow me up, so I'll let her take the majority of that. And then I'm going to end it with describing how we can actually help you potentially on everything else. But I know the first question on everybody's mind, and I want to address it because I think it's an important one. What? What is this? What is Dr. Savage doing? He's dragging us out of our homes, bringing us into this basement cellar of an auditorium on a summer night. He's a successful doctor. He's got a full practice. He's in his 40s. He's blowing it up. What in the world is he thinking? He's putting his family at risk. What in the world would make him want to do that? Well, before you can answer the question what, you have to ask yourself the question why? Why would a doctor do this? It's not a rational thing to do if you look at it from the trajectory of a profession. I'm starting over. And I already built what my whole life I was working to achieve. And the sad truth is it's because the system's broken. I don't think I'm telling anybody something shocking to say that the medical system is in chaos right now. Prior to 1965, it was around 4% of gross domestic product, meaning entire economic output of the United States. It's approaching 20% and going higher. Lower quality, shorter visits, higher costs. It is not a good thing. And the reason why? This guy right here. The 800-pound gorilla that is now in the exam room every single time you come to see the doctor. Now, not surprisingly, look at what he's got here. He's got the piggy bank. Because the whole system is now congealed around the piggy bank. It's gone away from these people right here, the doctor and the patient. It is my firm belief that if we don't do something, and I think not only myself, but many other doctors who recognize this, and many who will be recognizing this soon, don't do something, my profession, as we have historically been known, will be destroyed. The doctor-patient relationship, as many of you have come to know for the majority of your life, will cease. And one of the reasons why is because they're changing how doctors are reimbursed. Oh, come on, this is about money. The doctor wants to make more money. This does not have anything to do with the amount we are reimbursed. It has everything to do with how we are reimbursed. The system is moving to something called a shared risk arrangement, also known in some sectors as pay for performance. Now that sounds great, right? Who doesn't think a doctor should get paid based on performance? I mean, I sure do. When I first heard about that, I was excited. I thought, oh, thank goodness. We're not just going to be running in and out. We're going to be paid on quality. But performance according to who? According to you? No. According to the gorilla, that guy. What I call the governmental insurance company cartel. They run everything in medicine. So it's performance according to them, and I am quite convinced that their idea of performance is diametrically opposed to what you would consider performance. And let me just give you an example. So let's say you're walking along, happy as a clam, step in a hole. Ugh! Blow your knee out. Knee bends backwards, it's all swollen. And your mic doesn't work. I mean, it's terrible. Anyway, so is it better without it or with it? With it, okay. I can be really loud. All right, anyway, so mainly if I step in a hole, my knee bends backwards. Your knee is all swollen up. You come into your doctor. Oh my gosh, this hurts so bad, doc. It's so swollen. I heard it pop, and I could barely bear weight on it. Yeah, I think I need an MRI. Well, the doctor may look at you and go, ooh, yeah, that does look bad. Look, it's all shaky. Maybe you blew an ACL out. It's like, yeah, I think you do need an MR. Wait a second. Let me think about this. If I order that MRI on you under these new models, that goes against my high-tech utilization rating. That's considered a bad thing according to the insurance companies. I ordered an expensive test. Up to 1/3 of the quality is based on how much we don't spend. So because I order an expensive test on you, they now lower my rating. It's like a grade rating. And you go, wait a second here. They needed it. Look at his knee. It's a mess. I mean, he may need surgery. We don't care why you ordered it. We care that you ordered it. And because you ordered it, we're going to lower your quality. You are now considered a less quality doctor, you're a bad doctor. We're going to post that online. We're going to let everybody who comes to that website see it. You're now considered a bad doctor. People come online, ooh, Dr. Savage, bad doctor, that's interesting. Oh, he suspected it, but now I've got proof. All right, hopefully that's not the case. Oh, he's a bad doctor. What they won't know is that I'm a bad doctor because I did what was right for you. But then it gets worse. So now they look at that lowered rating and they use it to determine my reimbursement, not for you and every single patient I see. So is that not a conflict of interest? I can't imagine what a bigger conflict of interest than that. So this is an extreme incentive for doctors to not always necessarily do what's right for you. So now you go back and you see that doctor and he's under this kind of model. You come in, same scenario, oh, it's so bad. Oh, maybe you just walk it off or something. I'm sure you'll be fine. And believe it or not, it still gets worse. That's 1/3 of the measurement. The other 2/3 are based on biometrics, measurements. Got a couple extra pounds on you? Ooh, you have a bad doctor. So now, or you have some other measurements, lab measurements that aren't right? Ooh, bad doctor. So if you think about this, what does this start to incentivize? Who has bad measurements? Sick people have bad measurements. Well, sick people, so that hurts the doctor. You're sick, you come in, you have bad measurements, bad doctor. Ooh, bad measurements. Sick people are seeing you, bad measurements, must be a bad doctor. Oh, and now, because they're sick, you ordered a test. Ooh, double whammy, really, really bad doctor. So it's incentivizing doctors to avoid sick people. The doctor who's going to make a killing in this model is a doctor who's sitting back, taking care of people who don't actually need taking care of. Young people, perfect measurements, no abnormalities on their labs. That doctor's going to be sitting back, margarita. Of course, that's probably get him into trouble. But sitting there relaxing. He's going to be making a killing. The doctor who's doing what we're trained to do, which is take care of the sick, is going to be working his tail off and told by the insurance companies that he's a bad doctor. That's just the tip of the iceberg. If you guys want later, I'll go in. We're going to have a Q&A section at the end. I'll start telling you about some of the other changes that are going on. It's scary. It's going to destroy our. I'm sure every single person in here has already felt it to a certain extent. If you're not feeling it in the offices, you're faster paced, being hurried in and out. You got nurses from insurance companies calling you for no apparent reason. All these other things. There's a bunch of twists and turns as to how the insurance companies get reimbursed as to why that is. All these other changes. If you haven't felt it in the care yet, you will, and I'm sure you're all feeling it in your premiums. Now, I wouldn't be a problem if I didn't think there was a solution. And that solution is your choice. Now, direct primary care is a concept. Your choice is my version of that concept. As I said, this is changing on a day-to-day basis. This is coming. This is coming, and very soon. There are visceral associations occurring right now between doctors all over the community who recognize, like I did, that our profession is in real jeopardy here. If we abdicate our role as your advocates, why did we go into medicine? And we're not going to do it. And it's got nothing to do with the monetary issue. It's got everything to do with the conflicts of interest that are being artificially injected. And if they didn't think we're going to alter our behavior by putting these systems in place, why would they put them in place? They know they're going to modify our behaviors. Well, what were we doing that was wrong? Well, it's not hard to figure out because they put it in their literature to change doctors' behavior. It's right there in the literature. They also have in the literature to change patients' behavior, so be kind of cautious of that too. I don't know exactly what they mean by that yet. But anyway, under this model, how do we get out of that coercion? Well, if they pay us, they control us. So the only way out of that is I'm not going to take any payments from them. If they pay me, they can tell me jump and I have to say how high. But the only way to get out of that, unfortunately, is actually work for the patient. Ooh, that sounds scary. Well, I hope here in the next 30 minutes or so I'll explain why that shouldn't be so scary and how in the aggregate, and I need to stress that, not any one bill, what you pay over the course of an entire year or even several years will hopefully be much, much less in this. Why in the world do we think it's cheaper to pay a big fat middleman, the insurance company, to pay for your medical care? You need them. I'll explain in a second. You do need them to a certain extent. But to do for things like me, we really aren't that expensive. To pay an insurance company to pay us just dramatically increases the costs. Anyway, in direct primary care, they all have one thing in common. None of us get paid by the insurance company or the government. Some are a fee-for-service model, meaning you pay when you come in. Everybody recognizes that immediately as that is a cash pay practice. We have decided to take a twist. We're a membership model. We're going back to the way it used to be prior to 1980 when the doctors worked for the patients. But we decided there were some problems with that model. The fee-for-service, the doctor got paid only when you came in, and I'll explain why. Because it limits how you can access your care. It limits the ability to adopt new medications and new ways of practicing medicine. So we have converted into a membership model. In fact, it's kind of like a gym membership. If you're my patient, you're my patient. You need something, you want to come in, you forget your wallet, uh-oh. No, whatever, you're my patient, come on in, we'll take care of you. You're a member, there's some co-pays. Come on in, we'll take care of you. Or other ways of accessing your care. So what's included in a membership? Well, all your office visits. This is important. Why? That bizarre tension I was talking about between doctors and patients always existed. Just a couple weeks ago, I saw an interaction between the neurologist who timeshares out of my office and one of his patients. She came to the window and said, hey, can you get and I'm not going to say his name, can you get the neurologist up here? I want to talk to him just real quick. And I could overhear both sides of the conversation. I was kind of in between. And it was interesting because I realized neither one of them recognized where the problem was. And he got the message and he said, no, you put her back. If I'm going to be answering the question, this is what I do for a living, I'm going to get paid for what I do. And they relayed the message. Wait a second, I don't want to pay. Just a quick question. I don't want to have to pay a $45 co-pay for just a quick one. Just come on, just have them. No. So they ended up in somewhat of an argument. And the reason is because of this model. Under the current model, fee-for-service, under this model, where he's a member, he would have said, come on back. Hey, it's on the house. Not really. I mean, she paid for it in the membership, but, it's a different way of paying it. Come on back. And she would have said, oh, great. Great. I get to sit down and talk about the issue that's bothering me. She would have had no qualms about that, no payment. Or he alternatively could have went up to the front, assuming he's being cautious of her patient information, and talked to her right there. Either way, it takes away that artificial barrier of physically having to sit face-to-face to each other for our time to be reimbursed. And I'm going to come why that really fundamentally changes how we practice medicine. But all your visits, your wellness visit, your sick visits, I'd actually argue that distinction goes away. If you actually look at this book here, this is one of the coding books that creates rules for medical, just one of them. They say on a wellness visit, when you come in for your physical exam, we can't talk about sickness. If you come in and you happen to have a broken arm, oh, tough. Hey, that stinks, but you're here for a wellness visit today. That's not well. You can come back tomorrow and deal with a broken arm. What are you talking about? It's a broken arm. This is a ridiculous artificial distinction that started around 1972 when they had to introduce these coding and billing laws. Under this model, it's not a wellness visit, it's not a sick visit, it's a doctor's visit. We can address anything a doctor addresses in a visit. You come in, we'll take you. You want to do preventative services? That's a wellness visit. You got an issue that's going on, it's bothering you? Shoot, let's do it. I'm your doctor now. Let's get out of this bizarre tension that's existing because of those artificial rules that have been hoisted upon us. What else is included? All in-house diagnostics. Need an EKG? Let's get it done. Need a spirometry? Let's get it done. Pulse oximetry? You need a strep test or a mono test or a flu swab or anything we do in the house? We wrap it into the membership. Sure, we'll just do it. Let's stop the nickel and diamond. Let's stop the code focus. They call it patient-centered medical care. Everything in the system's a misnomer. It's not patient, it's payment-centered medical care. Hey, Rachel, did you get the code on that 50-cent urinalysis? We got to bill that out, we got to make sure we capture every little nickel and dime here. And oh man, I got to put a lot of time. Oh wait, you had another question. Wait a second, I'm still trying to get the code in for that 50-cent urinalysis. No, just do it. It's, these things are inexpensive. We include them in the membership. We're going to do what we need to do. By doing that, we're actually committing more time to you as well. We're getting away from all the tomfoolery. Other things, the procedures, same exact issue. You need a joint injection, a basic biopsy. Okay, pathology I have to send out. You could get a bill for that. But the procedure itself, You need a cryotherapy, meaning like wart removal. You need an ear lavage. Anything we do in-house, that's also included. So it's a wrap price. So you know how much your primary care is going to cost in a year. It's never going to cost more than that, even if we start doing joint injection, these other potentially expensive procedures. And this is the real exciting one, virtual home visits. It's also known as telemedicine. I think virtual home visits is a much more apt description. Remember this membership model? This facilitates this. Why is it impossible to get a doctor on the phone? Anybody know? You got it. She works in a medical office. She understands these things because we are not reimbursed for that time. So if people, there is probably 40% of what we do in medical offices, I would argue you do not have to be physically present to do it. Well, why do you have to be there? Because it's the only way we as doctors are compensated for our care is if in our time and our expertise and our training and our liability and everything else is if you are physically present. So if as a doctor I spend 5 hours a day on the phone talking to people, I get compensated zero. Rachel is drawing an income. You know, my staff is getting paid, so I'm losing money like crazy, not bringing in a dime. We go out of business. It's financial suicide for a doctor to do so. Under this model, it's a membership. Well, great. You want to talk on the phone? Well, how else? You want to Skype? You want to Skype? You want to text me or send me an email or something? Hey, I've already been compensated. You compensated me in the membership model. Great. Well, if it's convenient for you, let's do it. As long as it's not malpractice. I'm not going to tell you, hold the receiver of your phone really hard on the cut and hopefully the bleeding will stop. I'm not going to do something crazy like that. But something that can be handled on the phone or through technology can be done. And if new technologies come out that don't exist today, we don't have to wait for the billing and coding systems to catch up. They still don't fully recognize a telephone. That's not a new technology. They actually have a code for it. I'll give them that credit. But no one compensates for it, no one reimburses for it, and even if they did, the documentation to go along with a telephone is so abhorrent that no doctor would still do it. Let's just get rid of all that unnecessary stuff. We're going to document the pertinent stuff, but we're not going to document the unnecessary. What's an example of this? I saw a guy the other day. He's a plumber, great guy. He came in for a hypertension check. I fully believe physical exams are worthwhile to look for random pathology, a bump on your skin or something that pops up that you didn't recognize was there intermittently. But mandating you come in and we put a stethoscope on your chest every 6 months because you have hypertension is actually probably unnecessary if you're well controlled and you're not having symptoms. We could potentially stumble on some pathology, but the chance is pretty low. So why do we have to do it? Well, again, because that's the only way we get compensated. And many times now they're moving to outpatient ambulatory monitoring, meaning the numbers we're relying on, we're not even generating in the office. You're bringing your numbers from home to us, putting them down. Great. Oh, look at your blood pressure numbers. Oh, good. Okay, great. Well, here's your labs from the other weekend when you were off work and you came in. So let's just sit down together and look at those pieces of paper together. Oh, they look great. Okay, good. We'll see you back in 6 months. Why did you have to be there for that? I'd argue you don't. You still have to stick to national standards of care. Monitoring every 6 months is important, but in that situation, you are monitoring. You can get a history over a phone or a text message or an email. How about this? You get insomnia some night. You're up at 2 a.m. Oh, gosh. Hey, it is about 6 months. Let me send Doc my blood pressures. Hey, Doc, my blood pressure's been doing this. Hey, did you get my labs from last weekend? The next day, I can come in the office. Yeah, I did get your labs. They look great. Hey, wonderful. Any troubles with the med? No, I feel great. Okay, good. See you back here in 6 months for your wellness visit. Done. I asked this guy, the plumber who came in, I said, what would you have done today if you weren't here? He said, Doc, every time I come to see you, I'm trying to do his voice, every time I come to see you, I take a day off of work. I said, oh, wow, how much you make in a normal day? He says, over $300. I said, oh my gosh. He goes, I told him, this visit didn't cost you $140 like you think it did. He had a high deductible plan. I said, that cost you $440. You had $140 for the visit, and you had $300 in lost wages. That's something called opportunity cost. Now that could be work, but that could be just enjoying your life too. You know, maybe you had to cut out on your family or go to the golf course or something like that and you didn't get to do something that you enjoy or see the grandkids or something. Now, I mean, we got a beautiful waiting room and the music is fantastic, but you probably have something better to do than sit out there if it's not necessary. Anyway, here's another example. So imagine, you see the wavy lines. It's a Saturday afternoon. Oh, You get a rash. Oh, it's so itchy. It's driving me nuts. Okay, I was in the garden yesterday. Oh, gosh, it's poison ivy. Oh, I got to wait until Monday. And I call Savage's office. He's one of those insurance doctors, though. He's got 3,500 patients. Oh, man, he probably won't even get me in on Monday. Maybe it'll be Tuesday. Or, gosh, I don't know, maybe even Wednesday. Geez, you know what? I'm just going to bite the bullet. I'm going to spend a bunch of money. I got to go to the ER. This is driving me nuts. Now, forget all that. That's good timing, it going away. Get out your cell phone. Take a picture of it. Your cell phone, take a picture of it. Text me the picture. Why not? It goes right through my EMR, my electric record system. I get the picture. It freezes into my EMR. Hey, doc, I was in the garden yesterday. Got this itchy rash. You think it could be poison ivy? Why, that does look like poison ivy. Try some betamethasone. I'll call it in for you. Let me know if you don't feel better. Done. Good medical care. Efficient, saved an ER visit. Convenient, easy, and appropriate. That wasn't malpractice. I got a picture, I got a history, I got a treatment plan, I got a follow-up. It's great for us too. 2 sentences. Try some betamethasone, let me know if you're not feeling better. That's a treatment, that's a recommended follow-up. Now imagine if they did wait till Monday. Now I'm one of the few docs who still schedules in 20-minute slots. We're actually going to 30 in this new model. But I love him. I saw one of my friends say he's a family doc. He's scheduling 15. He's actually cutting them lower than that most likely in the near future. Because of the pressures that are on doctors nowadays. So what if you did wait till Monday? Well, now because we were able to handle it this way, even if we did it on Monday, it took 2 minutes. I didn't have to dedicate a 20-minute slot to something that took 2 minutes to treat and have to do a mountain of documentation and billing and coding and all these fiascos. And God, I hope the bill went through right, or otherwise you guys may end up on hold with our wonderful billing department. So now you handled in 2 minutes what could have taken 20. You didn't have to call, wait on hold, wait in our reception area, come to see us. God forbid I'm running behind. Now we handled it in 2 minutes, efficient, convenient for you, wonderful, convenient for us too. 2 minutes. But you know who else it was really good for? The really sick person who is just discharged from a hospital. 20 minutes isn't enough. Well, now I have 18 extra minutes I could dedicate to their care. 38 minutes. Maybe that'll be you someday. I present this as though you're the person with the rash. What if you're the person who's really sick? And you need that doctor instead of going, yeah, you're in the hospital. Okay, well, bye-bye. Now they go, oh, wow, you're in the hospital. What can we do to keep you healthy? Make sure you don't end up back in that hospital. And let's make sure we tune everything. Now I have 18 extra minutes I could dedicate to their care, 38 minutes versus 20. It was great for the person with the rash. It was good for us. It was great for the patient by just changing how we pay for it. That gives us the freedom of time allocation. The doctor to have the freedom to say, I'm going to distribute my limited time resource in the way that best helps my patients. So one of the ways we do this is through improved access. I have about 3,500 patients currently. That is not unique to me, ladies and gentlemen. That is the HMO model of care in the United States. I'm going down to 1,000. Why 1,000? Well, it's still a busy, even though the graph clearly shows just how dramatic of a change in patient volume that is still a busy practice, and if we're going to be providing a higher level of care, we have to have the time to do it. So we're going to have fewer patients giving them better care. But we are able to do this, and why 1,000? The reason why is because that's a historic norm. This is the aberration. Prior to 1980, this is what the average doctor saw, about 1,000 patients as their entire census. So we're going back to the way it used to be, back in the era, and some people I see gray hairs may remember Marcus Welby. You don't see too many Marcus Welby shows. The big one was House, and he was like yelling at his patients and stuff. So, which I admire that guy immensely. So anyway, so how do we do this? So there is something called concierge medicine. We are not that. Let me just end that right now. This is not what we are. Concierge medicine accomplishes somewhat of the same thing, getting a low patient volume, and they do this by charging what's called a retainer. These things are confused with the membership or paying annually for medical services. That has nothing to do with the provision of your care. That is just extra revenue so that they can keep their volumes low. Their patient census is low. Our fee is your care. We are not charging you a retainer. They charge you the retainer, and then they still charge your insurance company. They're still under the control of your insurance company. They still charge you co-pays. They still charge you for your visits. They didn't change anything other than just say have fewer patients. We change everything, and we do it not by charging you more. The hope is, again, in the aggregate, we charge you less, But we do it because we decrease our overhead. The insurance, trust me, it is a massive time constraint, massive expenditure to deal with the insurance companies and the government. When we say we're going to work for our patients and we're going to do it in a much more simplistic fashion, we can cut our overhead in half. Our costs of running a medical practice are cut in half. So we don't negatively impact care at all. We make it much better, and we are able to take care of fewer people and give them better care without increasing the cost to those patients. Oh man, that's a lot of stuff we talked about. Boy, office visits, what does this stuff cost? I mean, I'm telling you, okay, offices look great, what is that worth? Well, if you go by healthcosthelper.com, Blue Cross Blue Shield of Massachusetts, I got some of these numbers off the Mayo Clinic, they had a sheet. The average office visit in the United States, you know what it costs? Anybody want to guess? No, I wish it was $40. $187. For wellness visits, it's $252. EKG, $50. These are what they bill out at. Holter monitors, $350. Knee injections, $300. That's cheap. She worked in an ortho office. Well, this is cheap. What about in YourChoice? The office visits are included. The wellness visits are included. The EKGs are included. The Holter monitors are included. And the knee injections are $300. Wait, that's not right. Wait, this has got to be wrong. They're included. All right, it's cheesy. I got to keep that awake here. Yeah. So now that's a lot of stuff. That has got to be worth a lot of money. This has got to be oh geez, now here comes the prices. This is going to be expensive, isn't it? Well, probably a lot better than you think. You can get all of that. Unlimited visits, all the in-office procedures, diagnostics, virtual home visits, uncompromised care, better access, better care, starting as low as $39 a month. And it gets better. Spouses, 10% off. Okay, this is the sales pitch part. If you want to pay annually, it's great, easy for us. We'll just throw it in the bank now, you're good for a year. 2 months free. It's easy for us too. I don't want to think about money. Just be done with it, you're good until next year. We'll give you 2 months free for doing that too. Here's the best part of all. No hidden fees or copays. This is not a scam, ladies and gentlemen. This is it. That's all you'll be paying us. I'll explain a little bit later how we may be able to save you money in other regards through using our practice as a pass-through essentially for something. But for us, that's it. Anything we do in the office, that's it. I love numbers. Come on, who loves numbers? Okay, all right, that's not getting people excited. I love numbers. So I started looking at this and I'm going, man, if you start throwing some of these discounts together, what does that break down to on a daily basis? I mean, what if somebody was a spouse? So they got the 10% and they decided to pay annually 2 months free. How much is the daily cost of something like that? It's as low as 96 cents. 96 cents a day for unlimited visits, all the diagnostics, all the testings, the procedures in-house, the virtual home visits, what I haven't even talked about, access to cheaper testing outside of us, which I'll get to in a bit. And I thought, so this is important too. If you have an HSA or an FSA, if anybody knows what that is, that's a pre-tax account. For people with high deductible classic insurance plans, they can put money away tax-free that they can use for medical purposes. This had been a debate in the medical community for a while, but I got recent confirmation from my direct primary care attorney, there aren't a lot of them out there, but she's an expert in the field, that this is coverable. This is ACA, Obamacare, actually makes us needed, ironically, because it changed the system so much, but it also makes us legal. It makes us legal. And I'm just saying, well, okay, well, what if somebody uses their HSA to pay for this? And they're in a 30% tax bracket. Well, what does that daily cost? Whoa, my screen's on fire here, guys. Hold on. Okay. Sorry, okay. Animation overkill, I know. It was really cheesy. There's cheese in the back, too. I ate too much of it before we got going. All right, so that starts as low as 67 cents a day.
Well, that's less than a cup of coffee, Chad.
And that brings up the question, how much was your coffee this evening? You're going to be up all night. You're all up all night. The bathroom's that way too if you drink more of it. All right. And then if it's based on age, I am sorry, it could be as much as $1.19 a day. I mean, I know it's pretty bad. But this is a hidden value. We didn't really talk about it. How much is it worth to you to know that your doctor has your back? That your doctor is your advocate and fighting for you? Well, I'd argue it's priceless. So let me talk for a moment about insurance. Now, I'm not going to belabor this too much. Sue's going to follow me up and talk a little bit. But believe it or not, despite everything I said, I don't hate health insurance. I actually think everybody in this room should have health insurance. I love health insurance. It helps prevent bankruptcy. This is good stuff. You just shouldn't cover me under it. You should not overpay for your health insurance. That is an epidemic of insurance company overpayment in this country right now. So we're looking for ways to try to decrease your overall costs. We accomplish that in many ways. One is looking at your insurance company. Do not pay them to pay me if I'm not taking a payment from them. First of all, even if you did it that way, again, you're paying a big fat middleman who's going to take a lot of that money. Well, they don't just easily give it out to you after taking all that money. Now they get their tentacles in everything we do and try to control us and coerce us. Don't pay them. Keep the money in your pocket. When you have the money in your pocket, you have the power. When you give it up to them, they have the power. Keep the money in your pocket. Be smart about it. Save it. Don't blow it. Make a rainy day fund. If you do get sick, have it there for you. But keep it in your pocket or go invest it with Patrick Financial or something. Anyway, so again, insurance products, high deductible PPOs work wonderfully for us. However, I want to make people aware of it. This is a hidden gem that a lot of people don't know about. This is an alternative to the classic insurance-based products that a lot of people have. These are called the Christian health sharing options. For people who are Christian, the majority of these you're right on board. The neat thing about Liberty, it's based on Christian principles of sharing, but you actually don't even have to be a Christian to use it. And they have a really neat product that's called Liberty Direct. Why do I love them? They don't call premiums and deductibles, but they're equivalent of a premium or something similar to a premium that they have their monthly share. They cover us. The memberships I just talked about, you forget about them. If you get Liberty Direct, we're actually baked into their pricing structure. We work directly with them. So it's very much like an insurance company that works with direct primary care doctors. It's going to change everything. This is new since my last presentation just a week and a half ago. I'm telling you, this stuff is coming. There's a visceral association, a bunch of doctors like us all congealing right now to go right to employers, work with them directly, decrease the middleman as much as possible. We're going to decrease costs. If you can believe, I'm sorry about all the visits involved. The thought is having all your visits included in your membership. They found, if you can believe Q-Liance, which is the biggest medical practice in the United States, is doing this, they claim that they decrease hospitalization rates by about 20%. And it makes sense. Because if you're sick, I got this chest pressure, and I don't want to go in. It's $150 if I go in there, and I'm sure it'll just go away. Now you go in, people access care at a more appropriate time. We catch the disease states earlier in a more treatable state. So anyway, each of these are designed differently. Samaritan's the biggest. Liberty's got that neat direct care, Liberty Direct option for you. They can work with employers under 50. You can essentially give them health insurance without health insurance, without the classic health insurance. Again, I have to be careful. It's not health insurance. If they get labeled as health insurance, they are going to be just destroyed by regulation and their prices are going to go up so much. They are literally about the third the cost of classic insurance plans. My own family is switching to one of these as soon as I leave the hospital system because I will lose my classic insurance. I'm not overpaying for that. These are wonderful options. But for a moment, each of them are designed a little differently, but I'm going to focus on MediShare. And the reason why is it's set up in a way that's very easy to compare to classic insurance-based products. It has a deductible, essentially, your monthly share, and it has something similar, a premium, essentially, your monthly share, something similar to a premium, and essentially a deductible. For people who don't know what premium is, that's what you pay every month. Deductible is what you have to pay before your insurance does anything. So they call them different names, but they have things that are similar. So you can kind of compare them. You can actually do a reasonable head-to-head comparison. So what I did is I went to ehealthinsurance.com. It's an online website. Anybody can go there, verify my numbers. I did these in May, so these could be changed a couple dollars. Actually, if anything, they're going up. The estimate in the state of Michigan, according to ratereview.gov, is that the increases proposed for the state of Michigan are anywhere from about 11 to 38% for next year alone. There's a new tax coming too. It's going to generate about $8 billion in new taxes upon insurance plans next year alone. It's supposed to go up to $14 billion over the next couple of years. It is going to get worse, guys. But anyway, so in May, if the patients went on there and said, I'm going to pay for my doctor through my insurance. I don't want to mess with all this stuff, paying them directly and stuff. I'll just have my insurance company do it. The closest thing to that is a platinum plan. This one has a $200 deductible. That 59-year-old couple, if they don't have a subsidy, is going to spend $27,000 every year on their insurance. They haven't even seen a doctor yet. And let me be clear on this too. The doctor who they see is under all that coercion. 5-minute visit. So I would argue this person here is actually not even getting great care. Well, if they change just to a silver plan, which is a $2,800 deductible going up from $200 deductible, ooh, kind of scary. I'll explain in a minute why it's not scary. And they add us in, that little gray line there, 75 to 80% of your medical care is provided by primary care doctors. We are the ox with the plow in the medical field. We handle most things that affect people. That is actually the provision of your care. This is just the insurance. That's 75 to 80% of your medical care right there. If they got a direct care practice membership for both of them, they save in the aggregate versus the person who had the platinum almost $10,000 a year by just taking on a $2,800 deductible, which means even if they use it all, they're still way off. Now, what's funny about that $200 deductible, that's not it. You hit the $200 deductible, they will still nickel and dime you for another $1,800. There's something called co-insurance. You still have to pay co-pays when you come in, and you could pay up to another almost $2,000 on top of that. That is a car. That's a nice car every year. You know, we haggle on the price of cars for a couple $100. You could have bought the car. Anyway, every year. No one does that. Why? Why don't you buy a car every year? It's a waste. I don't think about it with this. Now here's the Christian-based health sharing options. This is MediShare. This one's a $2,500 annual family health share. That's something similar to the deductible. $2,500, this is $2,800. I would argue this is better than this. This one, how much they save in a year with us? You can kind of look at the graph here. $20,000. $20,000 in savings in 1 year. And people worry about paying us. $20,000 in difference here. And if they took on the high deductible plan, it's over $23,000 every single year. So one of my patients, businessman, I showed him this. I said, man, look at these. I showed him in a table with numbers and stuff. I said, wow, look at these numbers. It's amazing. I got to tell people. I can't believe people don't know about this. He said, wow, those numbers are impressive. You need to put it in graphical form. He was 100% right. So I put it in the graph. I started looking at it. I'm like, wait a second, that little gray line again. I'm like, man, geez. How many of these little gray lines would it take to go from here to here? And I started thinking about it. I said, wow, with the savings they got in 1 year, that couple, and remember, they're not abdicating their medical care. I'd argue they're getting better medical care. They're getting all those features I was talking about in the direct primary care. This one's 5-minute visits and coerced doctor. This is the better care. They would save so much in 1 year that they could have gotten unlimited primary care, all the procedures, all the testing, the virtual visits, etc., essentially for free for a quarter century with the savings by just changing their insurance in 1 year.
Which at 59 years old, that might be the rest of their life.
Yeah, so that was my next point. In 2 years, and if you were to backdate it, that could have been the totality of their adult life. Or they lived to 109, whichever way. And again, I was thinking about it. So the savings, again, we nickel and dime over cars. Oh, haggle back and forth. I could have saved $100. You could have bought the car with cash in 1 year's savings. And if you did it for 10 years, you could have bought a house. And that's where Mike comes in. Okay. They say the most expensive thing you're going to buy in your life is a house. It's a farce. The most expensive thing you're going to buy in your life, assuming you do this kind of thing, is your insurance. You could burn your house down and rebuild it for less than you're going to pay in your insurance over the course of your life. I'm not recommending that. But anyway, it's dramatic. We don't even think in this term. Most people get a 30-year mortgage because that's how expensive you got to take. You could have bought the house in 10 years with cash, without any interest or anything. Got your picture? All right. All right, but I just said, wow, don't be so scared of deductibles. I was mentioning the huge price difference in the premiums by taking on a deductible. That's pretty scary, though. Well, we make them less scary because we help with everything else. It's not just us. We've gone out and we've negotiated for you to try to get great prices. If you just say, you know what, there are times you have to use your insurance. If you get in a car crash, you're in the hospital, fine, you got to use your insurance. That's why you need insurance, okay? I'm not suggesting people don't have insurance. It's also federally mandated. You have insurance. Oh, I forgot to mention that. The Christian-based health sharing products, they qualify. You don't get a penalty for not having an insurance product if you have one of the Christian-based health sharing products. The federal government, they don't call them self-insurance, but I say they're insurance. Why? Because the federal government recognizes them as insurance. You do not get an ACA or Obamacare penalty if you have a Christian-based health sharing program, including Liberty. So again, you don't have to be Christian. They base it on Christian-based principles and values, and they have people attest to it. The one caveat on that, if you're planning on getting drunk and breaking a leg, that is, the Christian-based products have a couple of exemptions for if you did something that, essentially morality exemptions. If you decided to go on a shooting spree and your arm got shot, that may be something they would have trouble covering under the Christian-based health sharing. But anyway, so we have gone out and negotiated. Remember this MRI? Remember the thing that caused the problem? Oh, it's so expensive. We need to coerce those doctors and tell them, oh, I can believe it, because in Detroit, the average MRI bill's out at $3,461. Anybody want to share their experiences of what the bill is, not necessarily what you paid after your insurance, what the bill was of an MRI? I mean, they're really high. Yeah, I mean, they can be extreme. 3,500, yeah, right about what this is. So we've gone out and we've negotiated. And if you decide, I'm just going to go and I'm going to pay for it on my own, and what we have to do is it's called client services billing. They bill us for your MRI. They can't give you these prices directly because it actually violates their Medicare contracts and their other insurance contracts. But they can give us it. They essentially treat us like we're a hospital, and so you get the hospital prices. And what we do is we just pass them through. So that's the one thing that you could potentially have to pay us for beyond our service, but that's got nothing to do with us. What we're doing is we're facilitating better prices. They charge us and then we charge you. And by doing so, we allow you to get the prices that the hospitals get. Well, what do you think an MRI can be purchased through in that way if you were to pay cash for an MRI? This is, how much? Okay, you're beating me on this one. Close. $275. That is not a fictitious price. I had a patient who had no insurance the other day, had not accessed medical care in 2 years, was totally uncontrolled, diabetic, had acute neurologic symptoms. I said, oh my God, you need an MRI right now. She said, Doc, I can't afford it. I said, okay, I've been working on these pathways, talking to these imaging centers. I'm going to go call them up and say, hey, here's patient number one. What can you do? $275. She got an MRI. Thank God she didn't have something life-threatening. It turned out she was okay. But she got the care where otherwise she couldn't have afforded it. This is not for the rich. Sure, if you're rich, hey man, I'm happy to take you on as a patient. I'll give you great care. This is for everybody who can't afford their care in the current system. This is trying to make it accessible. 40% of people who have health insurance don't see a doctor because they can't afford the deductible. Well, what use is that? This is making it so those people can actually, this is wonderful for the working poor. That is a savings of $3,187 in one test. You could have seen me for many years, essentially for free, in the savings we got you with one test. Well, that's an imaging center. What about cardiac diagnostics? This is different. These are run through cardiologists. It's not run through imaging centers. Stress test, echo stress, that's a quality stress test. Imaging of your heart, 96% negative diagnostic probability, 4 years, blah, blah, blah. You're probably not going to have a heart attack within 4 years of having a negative test. There's no guarantees.
2,600. 2,600.
That's what you think? We get them for $207. $207. A couple Ben Franklins and you're done. That's what's on the 100, right? I'm not getting that wrong. All right. That is a savings in the average of $1,868. About chest x-ray. Average price here, $260, $460. Now think about this for a minute. Remember that MRI? I keep going back to this because they always coerce us in these MRIs. We get that towards the bottom of the range of what x-rays bill out at. This has fundamentally changed how doctors practice medicine. Doctors have to say enough is enough. When I trained in the 90s, algorithms were coming in, treatment algorithms. Oh, if a person has this, then you do that, and then you do the other thing. They have all these disclaimers on them. They said this is not to replace clinical judgment. These are only tools to assist with complex decision making. Great, I have no problem with that. However, they've now become mandates. You have to do this next step. You have to do this step after that. They do not allow for us to use our clinical expertise, the reason we trained for almost a decade, or more than a decade, I'm sorry, almost a dozen years. They don't allow us any flexibility in that. They say you have to do this, 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 and the other thing because MRIs are expensive. Well, that's a fallacy. They're really not that expensive. In fact, again, when what they bill out at, they're close to the x-ray range. But if you come in with back pain, it is very hard to get an MRI approved unless you got the x-ray first. They make you do x-rays even if we feel it's of very little clinical utility. And if we say, no, we're gonna go, remember again, they were gonna pay me less for doing it. If we say, no, I'm gonna be a good doctor. I know my patient needs that test. I'm doing it anyway. I don't care about the money. I'm doing what's right for my patient. I went to med school for a reason because I like taking care of people. Well, they say, ooh, we told you not to get it. We even threatened you financially. Now we're going to make it hard for you to get it. So then Rachel has to call up and sit on hold for an authorization. We have to get their permission to do this $275 study. We have to sit on hold and 40 minutes. And then she can talk and plead and beg, and they still may tell her no. And this last Monday was a classic example of that. We had multiple of these examples. Then they say, oh, no, Rachel, we don't trust you. You got to get the doctor on the phone. So now I have to call them up. And I have to sit on hold. Instead of seeing people and taking care of people, I'm sitting on hold with an insurance company. And then I have to do his peer-to-peer review. I mean, I talk to a doctor who's never seen you, never met you, never interacted with you or examined you in their whole life. And they can still tell me no, and you still are forced in back pain. Oh, gosh, do the x-ray. It's not probably going to help you, but you got to do the x-ray. Oh, but it's just going to delay me getting the right thing. I know, but your insurance company said that's what you have to do. Now, weeks of suffering may be added on to not only, it's just a waste, just a god-awful waste. Anyway, x-rays, what can we get those for? $45. That's a savings of $315 on the average. What about procedures? Okay, we don't have them all covered. This is really coming, I'll tell you too. Procedures, colonoscopies, those are expensive. $5,400. That's not an unusual billing rate for colonoscopies. Now the funny thing about these, and this is important to say too, if you do have creme de la creme insurance, you're overpaying for it. But if you do have it, you can use it under my model. If you got it, if you already paid for it and you can get the MRI for $100 or something like that with your insurance, I'll throw some codes on there, go down and get it done. You don't have to use these pathways. These are just trying to make it cheaper for you. But if you already paid that money and you want to get the better quality of care and you want to get the virtual visits and all the other things we do, you can still do them. You can still get all that. It's just we're working on trying to make this less expensive for you too. But how much can we get a colonoscopy for now? Oh, I'm sorry, one other thing too. Screening services. If you're 50 and you need a colonoscopy, most insurance companies will pay for this as a covered benefit. It's not free, okay? Don't think it's free. You paid for it. You paid for it in your premium. But again, you paid for it in your premium. We'll throw some codes, go to see the GI guy, get it done. So if you're just doing it just because, just kind of make sure you don't have colon cancer, they'll pay for it. But if you're bleeding rectally, losing weight like crazy, we think you have colon cancer, whoa, we're not paying for that. You got to pay for that. That's not a screening test. That's not a diagnostic. We will not cover, that's what the insurance companies will tell you. They will not cover colonoscopies when they're needed. It's crazy. So anyway, so now you got to do that colonoscopy. You got a $5,000 deductible. You're blowing $5,000 in one fell swoop. That's a lot of money. We can get it for you, $720. That's facility, anesthesia, gastroenterologist or colorectal surgeon, whoever does the procedure. That is a wrap price. You're not going to get multiple bills later on. And this is going to get a lot better. And the reason why is I'm really excited to tell everybody there's a cash-based surgical center coming in here pretty soon. The guy I talked to on this, the gastroenterologist, his price of this, the guy actually doing the procedure is $230. The rest is all facility anesthesia, and that's because of liability and all these other things. When that cash-based surgical center, which is akin to the Surgical Center of Oklahoma, which is Keith Smith runs that, he's an anesthesiologist, incredible pioneer in opening people's eyes to what these things really cost. This is going to only get better when that center opens up. We are at the hub here in Michigan. We have a bunch of primary care doctors doing this. There's going to be a patient base. I hope patients understand the value in this. So we're going to have hopefully a lot of patients understanding this, and we have even surgical centers that are going to be very friendly to this kind of model. We have the whole thing here about to come to fruition here in Michigan. We're very lucky to be around here. So that savings, fireworks again, $4,680. Depending on your age, you could have seen me for a decade. A decade for what you save on one procedure. And that's only going to become more profound, the difference between those two approaches. What about labs? The labs get so expensive. Cholesterol panel, total cholesterol, HDL, LDL, triglyceride level. $88 they charge out for. We can get them for $3.09. $3.09. That's a savings of $84.91 on one blood test. What about a CBC? CBC with the differential. That's a white count. Those are your immune cells. A breakdown of those immune cells. Those can suggest things like infection or cancer. It has hemoglobin hematocrit, which can suggest anemia. It has cell size. Cell size can suggest things like iron deficiency, folic acid deficiency, B12 deficiency. It has platelets, which are your clotting cells. Anybody who hasn't, I haven't already told them this price because I've told them, I'm just so excited about it, I have to tell people in the office. Anybody have an idea what this costs? $1.49. I heard 500 back here. Just a little off. $1.49. You spent more in gas driving over here than that test cost to do. That's a savings of $83.51. Now, I'll tell you this. That's the cost they tell us. What do we charge you? $1.54. What? Wait a second. That's more than $1.49. What's it? It's a credit card transaction fee. It's about 3% when you're on your credit card. So to get those prices, because we have to use our practice as a conduit. So they actually charge me, and then I charge you, and you swipe your credit card. So we have to pass on that 3% fee. We are not making a dime off of this. We are purely doing this to help you. So we have to, it's actually 3% on that. Okay, it's $1.54.5. We eat the half cent for just for you guys, because you guys came out tonight. All right. So, okay, so a lot of people say, okay, yeah, that's fine. That's what it bills out at. But a lot of people recognize, but that's not always what I pay. So again, I was trying to figure out, what do people pay out of pocket for these things? So healthcosthelper.com, again, I went there and I have no idea what they base this on. I said, what is the average out of pocket that people pay on labs? This is after their insurance. And they came up with a number of $283 to $675. Now, what I don't know about this is which tests specifically they included. They did not specify. So I went, okay, well, what's a fairly comprehensive series of labs? And I thought, well, what about a wellness visit? We do a lot on those. We do the CBC, we do the cholesterol panel. We do it's a CMP, that's a sugar level. It's kidney functions, liver functions, salt levels. It shows acidity, sometimes it shows calcium. We do thyroid levels, we do urinalysis. We can get all of that, $9.43. This is real world. This is what they're saying you pay after insurance. This is what we can get it for. Tack on 3% on that. But this is the savings. $469.57. Real savings. That's your annual membership, again, depending on your age. On one test, you do a couple of these, you're done. And the thing is when you look at this, these are over multiple years. When you consider how much you could save, this covers multiple years of us. So you can't even say, hey, but last year I was healthy. But this year I needed an MRI. Well, now you got 3 additional years for free on top of that. So not only covered this year, covered last year, and then 3 years into the future with the savings we get you on one test. So and I hear people all the time go, Doc, but I'm healthy. I never use it. Well, if you know you're never going to be sick, why? Yeah, sure. Why? If you know you're never going to use this, why have a membership? But if you know you're never going to ever need a doctor, why have insurance? You have insurance because things do happen. So we're not insurance. We're assurance. That if something happens to you, we're going to be there for you. Because we have a reasonable patient base, we have better access. You're getting the assurance to know that when you need us, you're going to get quality of care. So hopefully, I've explained what we are and why I think this is necessary. So hopefully I told you the reasoning. Hopefully I told you what it is that we are, how we work with insurance, and how we help with everything else. But in the end, this is your life. This is your money. And this is your choice. And ladies and gentlemen, that's why we're here.